I thought it would be useful to talk about something that I think a lot of pediatricians see in the outpatient practice. And, you know, there's really a wide variety of reasons why this may be happening. So what I wanted to focus on today, and I see children for a variety of reasons, but what I wanted to focus on today was joint pain in children. And there could be a variety of reasons why a child may be reporting joint pain. So my goal for the talk is to go through all of these reasons, and the large majority of them are actually not rheumatologic, but I do see these patients because when I see them, my goal is to rule out these other conditions, and I want to make sure that they don't have these other conditions prior to diagnosing them with a rheumatologic cause of joint pain. So hopefully this will be helpful, and again, happy to answer questions at the end. So we know that there's many joints in the body. We have big joints, small joints, we have intermediate joints, bigger joints being the knee, the hip, smaller joints being the joints in the fingers, the joints in the toes, and the intermediate joints, the wrist, the ankle. And all of these different joints can cause pain. And there could be a variety of reasons for all of these types of pains. So this is going to be just a very quick review of the different joints in our body. So here, just a nice easy one, the knee joint, big joint in the lower extremity, the hip joint as well. The shoulder joint is actually not a very common place where a child may complain of joint pain. It's a ball and socket joint. So here you can see here's the ball and then the socket. The neck joint is considered a pivot joint, so it kind of pivots around. And then here, the elbow joint is a hinge joint, and you can see that it kind of moves in a hinge-like manner. So what is arthritis? There's, like I said, many reasons that a child may be complaining of joint pain. Arthritis is one of these reasons, but it really is not the most common reason why a child may be complaining of joint pain. So I wanted to start out the talk by differentiating what joint pain is versus what arthritis is. So joint pain, the medical terminology for joint pain is arthralgia. And as you can see, it's just very short. The description is just joint pain. That's all it is, it's pain. Whereas arthritis has lots of different characteristics to it. So with arthritis, the pain is worse in the morning. So I may see a child who says, when I wake up in the morning, my knee hurts for 10 minutes, or my knee hurts until I start walking around. That really is more characteristic of arthritis. The joints also feel stiff in the morning. So I'll often ask patients, do you feel like when you wake up in the morning, your joints are stuck, or you can't move your fingers, or you can't walk around? And often this may last for anywhere from 5-10 minutes to up to, if it's more severe arthritis, maybe a few hours or even up to lunchtime. Arthritis, given that it's an inflammatory state, is characterized by joint swelling. And this is not always apparent to the child or to the parent or even to the general pediatrician. And that's often why I may be seeing the patient, because I've been trained to look for different joints and how they may be swelling in a different way. The joint in arthritis is warm. So it may be slightly warm. It's never really hot. That's more suggestive of an infectious joint. And then the patient complains of pain and limitations on movement of the joint. So they may not be able to extend their elbow when they're stretching. They may not be able to extend their knee when they're lying down. And there are different degrees of limitation, which I would assess for when seeing the patient, which will help me characterize whether or not this is arthritis versus arthralgia, because in arthralgia, we really don't see this type of limitation. So I'm going to be going through the variety of reasons why a child may be complaining of joint pain or arthralgia. So I'm going to be discussing arthralgias first and the different reasons why a child might have arthralgias. And then separately, I'll discuss the different reasons why a child may have arthritis. And again, remember, they're two different entities. Now, things that cause arthralgias really don't cause arthritis. However, things that cause arthritis may also cause arthralgias because they're obviously going to have pain as part of their arthritis. And that's kind of an important thing to remember as we move forward towards these different reasons. So this is not an exhaustive list, and I'm not going to go through all of them, but I would like to just kind of touch upon the more common reasons why I may see a child in the clinic with joint pain, and kind of what we're seeing more, more these days. So first, I'm going to discuss hypermobility. So hypermobility is essentially just someone who's very flexible. So they may say, oh, I've been told I'm double jointed, or my joints are loose, or I'm really flexible, I'm a gymnast, I'm an athlete. And this hypermobility or flexibility actually can cause quite a bit of pain in the joints. It's actually an extremely common reason why a child may complain of joint pain. The prevalence is up to 36% of children. And it tends to be more common in girls. Reasons are not really clear. And the reasons for the pain are also unclear. So there may be joint instability, impaired proprioception or sense of balance, causing discomfort, muscle strain because of these loose joints. And often family members are also flexible. Mom will say, oh, when I was younger, I also was really flexible. Sibling might be flexible. And rarely they can be associated with different genetic conditions. So things like something called Ehlers-Danlos or Marfan syndrome tend to have these hyper-flexible states. However, the large majority of children will not have an underlying genetic condition. That's just kind of how they're built. They're very, very flexible, and that's tends to be causing them some pain. And it tends to be most common in the legs or the lower extremities. So the knees and the ankles tend to be the most painful for these children. So what we see in these kids, and this is a photo of a child with extremely flat feet, the flat feet cause joint pain. So in the ankles or in the knees, maybe even in the hips. And this is something that I evaluate for when I'm examining a child who may be hypermobile. I'll have them walk and, I'll say, oh, have you ever noticed that your feet are very flat? And, then that'll kind of bring them to a discussion about that. So, one way to treat this hypermobile joint pain is by trying to create an arch in the foot. So the foot is not as flat. So, there are some things like shoe inserts that you could buy in the store, or online that try to create an arch in the foot that may be helpful. I find that usually sending children to physical therapy tends to be the most helpful for this kind of issue, because it really teaches, ways to stretch properly. It helps a great deal with muscle strengthening. So, if the child is really complaining of severe joint pains from hypermobility, I frequently will send them to physical therapy. Rarely things like medications such as Motrin or Tylenol may be helpful, but there's really not an underlying inflammatory condition that's causing this pain. So really just kind of working on maneuvers to strengthen the muscle tends to be helpful. Okay, so overuse syndromes. So this is another reason why I may be seeing a child with joint pain. And so what an overuse syndrome is essentially what it sounds like. This tends to be more prevalent in growing children, particularly if they're going through a growth spurt or if they're in puberty. What happens is as the growth plates are kind of accelerating as they're growing, overuse of these areas of the bone tend to cause pain. And so, for example, I'm going to discuss a few different types of the overuse syndromes. There's many of them, but these are kind of the more common ones. If you look over here up on the top left, this is describing a condition called Osgood-Schlatter's. Now, this is very common. And we tend to see this in active teenagers, active preteens who are maybe participating in sports. And as they're growing with this kind of strenuous activity, here you could see the child running and pressure on the knee. What happens is this tendon right here that connects the kneecap or the patella to the shin bone, and this is called the patellar tendon, it tends to become almost inflamed and overused, and that causes pain. And what will happen is the child will complain of pain and maybe even a bump. Sometimes it could be a quite prominent bump at the front of their knee, kind of just at the top of the tibia, the area called the tibial tuberosity. And it can be quite painful. So with these children, what I usually recommend is sometimes physical therapy can be helpful, but really more, easier measures such as stretching before and after an activity, ice application to the area, and even sometimes something like an occasional Motrin may be useful for these kinds of symptoms. Sometimes applying ice can also be helpful. Now, over here on the right, this is something called Sever syndrome, and this is an overuse syndrome, but this time we're talking about the ankle joint. So this is the Achilles tendon right here. And as you can see, it connects to the heel of your foot. It's called the calcaneus. And this is considered a calcaneal apophysitis. So essentially where the growth plate is right here at the heel is where the tendon is inserting. And this growth plate is painful due to overuse. So if you think about it, we're kind of using this area of our foot frequently. We all walk and we run, and some people may be involved in sports or dance, particularly children and teenagers. And this overuse injury becomes apparent around that time. So the child may be complaining of heel pain that, the parent or the child may think is actually ankle pain. So the treatment is similar to Osgood-Schlatter. So, icing after an activity, good stretching, and, occasional use of PT if really necessary. Now, the last type that I'll talk about is something called patellofemoral syndrome. And this is here at the bottom left. You're kind of looking down at the femur, which is the top part of our leg, and the patella, which is the kneecap. Now, sometimes what happens is children who participate in activities that may involve things like squatting, maybe they're a catcher in baseball, or they might be a rower, even going up and down the stairs. What happens is this kneecap becomes unstable due to compressive forces, and it kind of tracks, so it moves back and forth. And so what happens is this causes pain at the front of the knee, so where the kneecap is. Now, the recommendations are the same as the other two overuse syndromes: icing, good stretching, and oftentimes, we may have the child just take a break from that activity if it's really causing them pain, which is not always ideal because they want to participate in their sport or activity, but sometimes just rest from the activity may also alleviate the symptoms. Now, the next one is a little interesting. So I'm going to talk a little bit about one specific vitamin deficiency that may cause joint pain in children. So actually, vitamin C deficiency causes something called scurvy, which is kind of making a comeback. Usually we think of scurvy. Historically, it's been described in pirates because what happened is these, pirates back in the day would have these bleeding gums, and no one really understood why. And the reason was that they were actually deficient in vitamin C, which one of the symptoms of vitamin C deficiency is kind of like inflamed bleeding gums. But vitamin C deficiency actually can cause joint pains and muscle pains as well. And recently we've actually been seeing a lot of this. And, I'll kind of go into why. So vitamin C, where do we find it? So fruits, oranges, strawberries, tomatoes, things like potatoes, and many vegetables such as Brussels sprouts, cauliflower, broccoli, cabbage, and spinach, obviously all favorite foods of children. Vitamin C is an important vitamin to make something called collagen, which is essential in development of different skin and musculoskeletal structures. So what happens is we see this in children who are picky eaters. So children who don't want to eat the foods that I just described, which for the most part is most kids, but particularly the rheumatology community and other specialists who take care of children with musculoskeletal complaints find that children on the autism spectrum tend to have this deficiency more than others because of their very rigid eating patterns and rigid diets. I definitely have a higher index of suspicion for that if I'm seeing a child who's on the autism spectrum. They may have a variety of complaints, arthralgias or the joint pains, muscle aches, which are called myalgias. They may have weight loss, gingival hyperplasia, which is this thick gum that may sometimes be inflamed or bleeding, which you could see here on the screen. And they may have this very particular rash, which you could see here. It's kind of this pinpoint red rash that can be seen at the base of the hair follicles. And luckily, this is quite easy to treat once we diagnose it, because all we have to do is either increase their vitamin C intake or maybe supplement them with a vitamin C that can be prescribed to them. And the diagnosis is also quite easy. You get a vitamin C level, and then there's your answer. Often, interestingly, these kids tend to have quite an extensive workup because they're complaining of these diffuse joint pains. Nothing is really coming back in terms of positive labs or imaging. So these kids get kind of $1 million workup, and at the end of the day, it's something as simple as a vitamin C deficiency. So something to definitely keep your eye out for. Okay, and then the last reason why a child may have joint pain is something called an amplified pain syndrome. So I'll briefly discuss that. So what is an amplified pain syndrome? So there's a variety of different names for this. This is something that is kind of akin to fibromyalgia in the adult world. It can be called juvenile fibromyalgia, amplified musculoskeletal pain syndrome, or AMPS. Another aspect of it is called complex regional pain syndrome. So there's lots of different names. And basically what it is widespread pain in many, many joints without an underlying cause. So all of the different things we talked about so far, there's a reason why the child might be having pain, whether it be overuse, a vitamin deficiency, they're hypermobile. The two things I didn't touch upon, which were injuries, obesity, these are reasons why a child may have joint pain. With amplified musculoskeletal pain syndrome, there's really not an underlying cause. And obviously, before making this diagnosis, we need to rule out anything else that can be causing these symptoms. So often these children will also get a significant workup. And this pain in these children is really distressing. It causes them to miss school, miss social functions, really kind of retreat into their homes, which we're kind of all doing now. But in pre-pandemic times, this is, it would really be impactful of their social development, and their educational development. So the etiology for this is unclear. It's thought to be related to a dysfunction in a part of our nervous system relating to how we perceive pain. And children with amplified musculoskeletal pain are often have symptoms such as fatigue. They might have poor sleep patterns. So for instance, they may take a really long time to fall asleep at night. They wake up not feeling refreshed in the morning. They might take several naps during the day because they're really not getting the sleep that they need. Often these children have comorbid mood disorders, particularly depression, but sometimes anxiety. And these children often have headaches or migraines. They might have abdominal pain or irritable bowel syndrome. So these are kind of all clues to a child who may be having an amplified musculoskeletal pain syndrome. The difficult part is treatment. There is no medication to treat amplified musculoskeletal pain syndrome. In the adult world, some clinicians may use things like gabapentin or antidepressants to help the pain, but these have not really been studied extensively in children, so I don't recommend them for amplified pain syndrome. What I do recommend is attempting a multidisciplinary approach to the pain. So what this means is really working on strengthening the muscles and coping with the pain. And that's through physical therapy and occupational therapy. And often it can't really just be any physical therapist or any occupational therapist. I would prefer that the child sees a physical therapist who has experience treating amplified pain syndrome in children. And there's many, it's not hard, it's not necessarily hard to find, but it's just important that they see one of them. Cognitive behavioral therapy is important, or CBT. Seeing a behavioral therapist who also has experience in treating amplified musculoskeletal pain syndrome is extremely important. Again, these are not necessarily hard to find. You just want to make sure before sending the child to see that therapist. And then different lifestyle modifications. So we talked about sleep patterns, so improving sleep hygiene, making sure, obvious things like making sure that they are, not running around, exercising in the couple of hours before bedtime, no caffeine 2 hours before sleep time, no screen time 2 hours before sleep time. These are all things that can impact the onset of sleep and the degree of how refreshed they feel in the morning. And sometimes if these modalities don't work, there are actually several comprehensive outpatient programs and inpatient programs in many states. And we're fortunate enough to live in a state that has 2 of these programs. And we have another one nearby in Philadelphia. And these programs are really kind of for the more severe patients who have not had success with outpatient treatments near their homes. And these programs have specialized physical therapists, behavioral therapists, music therapists, art therapists. They may have a pain management doctor, a rheumatologist. It's really a core team that will work to improve the pain symptoms, which are quite debilitating in these children. And they're very, very good programs. And I've seen children do well once they've left. Okay, so now that we've talked about arthralgias, we're going to start talking about arthritis, which is inflammation of the joint. So just as a reminder, we talked about the differences between arthritis and arthralgia. So just as a reminder, arthritis is worse in the morning. Kids might feel stiff. Importantly, there's swelling, warmth, and limitation. And these are things I assess for when I'm seeing a child with joint pain. And often we think of arthritis as a condition that affects older people, and that is true, but this is an inflammatory arthritis. So it's akin to something like rheumatoid arthritis, which may affect adults who are maybe in their 30s or 40s or 50s, versus osteoarthritis, which is more of a degenerative arthritis of older age. So arthritis in children, like I said, is more kind of along the lines of the rheumatoid arthritis, inflammatory arthritis. So there's, just like in arthralgias, there's many reasons why a child may have arthritis. And I'm going to go through these more specifically. Some are more common than others, but I think it's important to just know that there's many, many things that can cause arthritis in children. So a very common reason why a child might have arthritis is infectious. So kids get infections a lot. Now we often think of one infection that a child might get, but it's not the only virus or infection in the world. And there's lots of different viruses, bacteria, even fungal infections that may cause arthritis. So viral infections are probably the most common reason why a child might have arthritis in one of the joints. And it may occur during the active infection. So they might have a runny nose and cough, other upper respiratory symptoms, and arthritis, or even might, these cold symptoms might go away. And then a few days later, they may start complaining of arthritis and they may have swelling in one of the joints. Really, any virus can cause a viral arthritis. Some of the more common viruses that may cause it are parvovirus, which usually presents with upper respiratory symptoms, and classically that kind of slap face rash on the cheeks. Mycoplasma, which technically I guess is more of a bacterial, but we kind of classify it with the viral infections just because it's more common, and it causes a milder arthritis. And this can cause different things such as pneumonia. And then mono or Epstein-Barr virus very frequently can cause arthritis. So the real treatment is really supportive. Obviously, we want the virus to go away. Once the virus kind of clears the body, the arthritis kind of follows. We want to make sure that the child is comfortable. So things like NSAIDs or nonsteroidal anti-inflammatories like Motrin or Advil or ibuprofen are helpful just to treat the symptoms. And that's really, that's really it, because these really do go away within the maximum amount of time, about 4 to 6 weeks, the symptoms will go away. Now, the next type of infection that can cause an arthritis is a more severe type of arthritis, usually from a bacteria called septic arthritis. So this is, like I said, typically a bacterial infection. And the main thing to note here is that septic arthritis is different than other kinds of arthritis that I may see, because the joint is red. So really with any of the arthritis that I talk about today, whether it be related to autoinflammatory or autoimmune, or even a viral arthritis, you're not going to have a red joint. A red joint, I would consider to be more of a medical emergency, because I would be concerned for an underlying septic arthritis. So the joint is red, it's very, very tender, it's hot, it's not warm, but it's hot, it's swollen. Often the children will have a fever. And this is a medical emergency that requires antibiotic treatment, whether it be oral antibiotics or IV antibiotics. If a child has these symptoms, they should be seen by a healthcare professional on the sooner side. On the right-hand side, these are just different bacteria that are common culprits that may cause septic arthritis. So, these are just a variety of different bacterial infections. But I did want to point out that in the adolescent population, gonorrhea tends to be a little bit more common. Something called disseminated gonorrhea causes a very painful, hot, red knee. And this you would just treat the gonorrhea and it would go away. Now, another type of infectious arthritis that I'd like to talk about are the arthritis related to strep. So strep pharyngitis, or even strep skin infection can cause a couple of different conditions that may cause arthritis after the strep has cleared. And these are conditions that occur with untreated strep infections. So a child may not know that they had strep, or they may not have been prescribed antibiotics, and then the strep can cause these two conditions. So the two conditions are acute rheumatic fever and post-strep reactive arthritis. Acute rheumatic fever is significantly more concerning than post-strep arthritis, although they're both concerning. But acute rheumatic fever can involve several other organ systems, which makes it a little bit more concerning. So this big chart here is a little busy, so I'll go through it. So what is a post-strep arthritis or acute rheumatic fever? So with acute rheumatic fever, which I'll discuss first, a child might have arthritis, but it's migratory. So what that means is they may have swelling in their knee, and then the next day they may have, and that will go away, and the next day they may have swelling in their ankle. The next day that goes away and they may have swelling in their wrist. That's really kind of a classic description for acute rheumatic fever. Now, if a child complains of this migratory arthritis, the clinician may be, concerned that this may be acute rheumatic fever, so they'll check for evidence of a preceding strep infection. And there can be a couple of ways to check this. One is just doing a simple throat swab, and this should be a strep culture to check for active pharyngitis, because remember, this is an untreated strep infection. Or we can check for antibody titers. So the body will develop antibodies, one called anti-streptolysin O or ASO, and the other is called DNase B, to a strep infection. And if you see this level at a very high number, or a number that is progressively getting higher, this would raise the concern for acute rheumatic fever or post-strep arthritis. Now, many children have elevated ASOs because children just tend to have strep a lot. So these levels tend to be high. So just the presence of an elevated ASO alone does not necessarily would concern me for acute rheumatic fever, unless they were accompanied by the symptoms that I'll discuss in the chart. If the number is very, very high, that might, pique my interest a little bit more, make me a little bit more concerned. But if it's a little bit above normal, it's usually not a reason to be concerned. Now, in order to make the diagnosis of acute rheumatic fever, you must have that evidence of the preceding strep infection, like I mentioned. And there's a couple of other manifestations that the child might have. So on the left-hand side of the chart, there's something called the major manifestations. This is something called the Jones criteria. I'll go through each of them. So the first one, and this is really the concerning one, and this is why acute rheumatic fever, I think, makes a lot of people nervous, is carditis. So it's inflammation of the heart, and it could really be any layer of the heart. But most commonly, it's one of the heart valves. So untreated, obviously, this can be dangerous. So this is something that we check for. If there's a concern for acute rheumatic fever, perhaps an echocardiogram and or EKG will be done. Another one is the arthritis that we talked about. Again, it's migratory. Sydenham's chorea is really not as common, and it's a later manifestation of acute rheumatic fever. And what that is, it's a neurologic condition where you may have a child who's kind of had this funny writhing type of movement. It almost looks like they're dancing. That could be a clue. This rash that you see here on the right, it's called erythema marginatum. This is, could be suggestive of acute rheumatic fever. And then at the bottom, you could see these subcutaneous nodules or little bumps under the skin that sometimes can go along with acute rheumatic fever. Now, in order to make the diagnosis, you need to have 2 of these major criteria and a preceding strep infection, or you could have 2 of the minor criteria and 1 of these major criteria and a preceding strep infection. And the minor criteria are more nonspecific things like fever, joint pains, elevated markers of inflammation, abnormalities on EKG. The treatment for acute rheumatic fever, from my standpoint, in terms of treating the joint pain, really would just be supportive in treating them with an NSAID like Motrin or something stronger like naproxen, or one of the other NSAIDs. But to actually treat the underlying strep infection and to prevent future occurrences and really to prevent the carditis or the valvular dysfunction, children who have acute rheumatic fever may be on prophylactic antibiotics for many, many years to prevent them from getting strep infections in the future. Now, post-strep reactive arthritis is kind of a milder version of acute rheumatic fever. Essentially, it's, the child may not meet all of these criteria, or they may just have arthritis after a strep infection. These children typically, and it's a little controversial, but these children typically will be on prophylactic antibiotics for about a year. And if at that point there is no development of carditis, oftentimes the child will be taken off of prophylactic antibiotics. But again, this is a little controversial, and everyone seems to do something a little bit different. And it also depends on the child and the risk factors. So the next type of infectious arthritis that I may see in the clinic is something called Lyme arthritis. So obviously from Lyme disease. So what's Lyme disease? So it's a tick-borne illness. So what happens is a tick that may be on a deer, or most typically deer or other wildlife, carries a bacteria called Borrelia burgdorferi. And what happens is that tick transmits this specific bacteria to a human when they bite them, when they're either hiking or camping or out in the woods. And Lyme disease can have a variety of different manifestations, which I'll go through individually. But the reason why I may see a child with Lyme disease is that they have Lyme arthritis. And each type of manifestation of Lyme is treated differently. And therefore, the child who has Lyme might have to see different specialists based on the type of Lyme that they have or the phase of Lyme that they're in. So there's multiple phases. So the first phase, the early phase, is when you'll see this typical bullseye rash here. It's called erythema migrans. And sometimes the child might not even have the rash. And more often not, they may not have the rash, but this is really right afterwards. And if it's identified at this point or the tick is identified, oftentimes the later stages can be avoided. Other things that may happen in this early onset is something like a flu-like syndrome or Bell's palsy, and goes through a variety of other symptoms. They might have other kinds of rashes. They may have conjunctivitis or redness of the eyes, other neurological manifestations. But by the time they get to the late stage, which is weeks to months after the initial tick bite, they may develop a fairly significant arthritis, and it says an oligoarthritis, and that just means in a limited number of joints. And usually it's just in one. It tends to be in a knee, and it's a very, very swollen joint. And that's usually when they will wind up in my office. So how do I diagnose it? How do I know that it's Lyme? So we do blood work. We do a screening test, which is called an ELISA, which measures antibodies to Lyme. And if this is positive, the lab will reflex it or automatically send it to another more specific test called the Western blot. So just because a child has a positive ELISA does not mean that they have Lyme disease. And that's something important to keep in mind. If the Western blot is positive, then at that point, I would start treatment for the Lyme arthritis, which is doxycycline or an antibiotic for about a month. Sometimes it doesn't go away after a month, and it may require 2 rounds of treatment or maybe IV treatment with something called ceftriaxone. But like I said, each Lyme manifestation is different and requires different treatment. So specifically for Lyme arthritis, this would be the treatment. And then I'll briefly go through these less common reasons why a child might have arthritis, but still something to kind of keep in the back of your head. So different medicines can cause arthritis. Medicines have lots of different side effects. Arthritis is one of them. So something called serum sickness, which I'm sure many of the pediatricians on here, are familiar with and see all the time. So basically what this is a reaction to, it's an inflammatory reaction to often an antibiotic like a penicillin or a penicillin-like type of medication, such as like a cephalosporin, which is kind of in a similar family to the penicillins. And often it'll be a couple of weeks after, or a week or two after the antibiotic, the child may have hives and joint pain or joint swelling. And sometimes it can be significant. So this is a pretty easy diagnosis to make if you know that the child has recently been on one of these antibiotics, and basically you tell them don't take this antibiotic in the future, but to treat them at the moment, really supportive things like NSAIDs, Motrin, Aleve, Advil will help. In severe cases, a trial of low dose steroids may help, but this is really for the kids who it's really more severe and they can't walk because the joint pain is so significant. Drug-induced lupus, also not as common as serum sickness, but I still do see it. So drug-induced lupus is not the same as regular systemic lupus. Drug-induced lupus can be caused by medications that may treat seizures or depression, antiarrhythmic medications, anti-acne medications prescribed by the dermatologist. And what happens in drug-induced lupus is that a child may complain of a rash, they might be tired, and they have these kind of non-specific muscle aches and joint pains. So if a child has drug-induced lupus, what I usually do, I take a history of what medications the child is on. If I'm concerned for drug-induced lupus, I check for a specific antibody that can be associated with drug-induced lupus called histone antibody. And if that's positive, that usually gives me my answer. And the treatment is just taking the child off of the medication. And it may take a couple of weeks for the child to feel better, but it resolves once they're off of the medication. And the antibody number might take a little bit of time to go away, but it eventually does go away. It is not a precursor to systemic lupus. It just has the association with that particular medication, which they obviously should not take in the future. Going down the chart to metabolic or genetic causes of joint pain or arthritis. Down syndrome can cause arthritis. And then lysosomal storage diseases, which are metabolic conditions that are usually diagnosed at birth, can have arthritis as one of their manifestations. And then lastly, kind of the more severe causes for arthritis, leukemia in children can cause arthritis. So obviously, if there's a child where you're concerned that this may be an underlying diagnosis, you should do a thorough workup to rule this out. Something called pigmented villonodular synovitis, or PVNS. This is a benign synovial tumor, often in large joints like the knee. And the knee tends to be quite large and quite swollen on MRI. Usually the diagnosis is found on MRI, usually treated by an orthopedic surgeon with experience in oncologic orthopedics. And it tends to be bloody. So if the joint is aspirated to look for different kinds of cells, the fluid is very, very bloody. And that also kind of gives the clue that this could be PVNS. And then lastly, hemarthroses, or blood accumulation in the joints. So children who might have conditions impacting their ability to clot. So children with hemophilia may develop hemarthroses. Okay, so the last section is really kind of, to me, the most important section because it's what I take care of. So inflammatory or autoimmune conditions that may cause arthritis. So all of the different things we talked about are things that I will assess for in a child who's coming to see me with joint pain, because I need to rule all of these out, because what I'm looking for is this last one, number 6, because these are the children that I will follow for the long term for whatever issues causing their joint pain. And I'm going to focus on really only one of them that tends to be a little bit more common. And, I'll briefly touch upon the other conditions that may cause arthritis that I also take care of. So I'm going to focus on JIA, or juvenile idiopathic arthritis. So JIA is quite actually common chronic disease of childhood. Its current prevalence is 1 per 1,000 children. And in order to diagnose it, there's a few criteria. So 1, arthritis before the 16th birthday. And really the only reason for this criteria is kind of semantics. After they're 16, they're considered rheumatoid arthritis. So even if it's the day before they turn 16, they're JIA. The next day they might be RA. Now, in order to be diagnosed, you have to have arthritis for at least 6 weeks. So this can be either historically, the patient might have joint swelling for months, or the rheumatologist will follow them and notices that they have arthritis for at least this period of time. And we use the 6 weeks because we want to exclude viral infections that may be lingering on in the system for a month or so. If it's longer than that, less likely to be infectious and more likely to be GIA. So we really would like to wait about 6 weeks. And then exclusion of all those other conditions that we talked about. Now, I'm not going to go through all of this, but this is a table just delineating the different types of JIA. There's 7 different categories of JIA. They all are different, and they all have different treatments, but I take care of all of them. So I'll skip the first one for a second, systemic JIA, but the next ones kind of just are based on the number of joints that the child may have affected. So oligoarthritis, so that just essentially means 4 joints or less are affected with arthritis. This is more common. Polyarthritis is just 5 or more joints. Psoriatic arthritis, enthesitis-related arthritis. These tend to be children who either have psoriasis or have a family member with psoriasis. They may have lower back pain or sacroiliac involvement. Kind of the juvenile precursor to ankylosing spondylitis, tends to be adolescent boys. They kind of fall into these categories. And systemic arthritis, systemic GIA, is kind of a whole other thing. There's fevers, a very distinctive rash, a very distinctive pattern of fever and rash, swollen lymph nodes, swollen spleen. So that's a whole different thing, but it is still considered a type of juvenile arthritis. So these are just some photos from the AAP and the ACR, which is the American College of Rheumatology, of children with JIA. On the left side, there's obviously a very swollen right knee in the child. And then on the right side of the photo is a photo of dactylitis, or a swollen toe. And you can see that third toe is pretty significantly swollen. And we see this in children who have psoriatic arthritis. So how do we diagnose JIA? It's a clinical diagnosis. There's no lab test that will tell us, yes, this child has JIA, or no, this child does not. We check for arthritis on exam that has been there for at least 6 weeks based on either history or evaluation. And kind of more supporting evidence of chronicity, or longer than 6 weeks, can be seen through different measures on physical exam, such as leg length discrepancy and muscle atrophy. So if you can see here in the photo, the child is kind of bending his left leg because it's longer than the right leg. And the reason for that is his arthritis. So arthritis is an inflammatory state. So what happens is our immune system, our inflammatory markers, everything that works and it kind of evolves around the inflammatory state, causes endothelial growth factors and vascular growth factors to accelerate in the joint. And this essentially causes rapid growth of the joint, and the joint tends to be longer. And it can be anywhere from 1/2 centimeter to sometimes maybe even over 2 centimeters difference. And muscle atrophy, essentially we check for atrophy in the thigh muscles. Over time, the inflammatory state of either the hip or the knee, whatever joint is affected in the lower extremity, may cause some muscle atrophy. So often I'll check for the diameter of each thigh, compare them to each other, just kind of as a reference. Now, as I mentioned, labs are supportive, but they're not diagnostic. Different labs we may check are antibodies that can be associated with juvenile arthritis, such as rheumatoid factor, ANA, CCP, HLA-B27, which is a genetic marker. It helps us with the diagnosis, but does not make the diagnosis. Same with imaging. There are some exceptions. For example, the TMJ, or the temporomandibular joint, right here in our jaw, can often be seen affected in juvenile arthritis. Sometimes it's asymptomatic. The child may or may not have pain with chewing. They may not be able to open their mouth wide. They may sometimes have micrognathia or small chin. So on imaging, so MRI of the TMJ joint, that will give us the diagnosis, whether or not there's active arthritis or evidence of past arthritis in the TMJ joint. The hip joint, obviously I can't check for fluid in the hip joint. The joint just, you can't check for it on exams. So I'll often get an ultrasound or MRI to look for arthritis there. And same with the sacroiliac joint. It's not something that you can check for on exam. So imaging is required to make that diagnosis. So something I'd like to mention is uveitis. Uveitis is inflammation of the uvea, which is a part of our eye that contains the iris, the ciliary body, and the choroid plexus. And uveitis tends to be not common, but it does occur concurrently with JIA in many situations. So what happens is either the child may have a painful eye or a red eye. They may complain of blurry vision, double vision, things of that nature. And the underlying reason would be the inflammation of the specific part of the eye. Uveitis can be seen in a variety of different rheumatologic conditions, not just JIA, but there's a certain subtype of JIA that it tends to occur more commonly with, so we like to monitor for that. So it tends to be more common in young females, specifically like under the age of 6, who have a positive ANA antibody and have oligoarticular juvenile idiopathic arthritis. So these children need to see an ophthalmologist right away to rule this out. Like I mentioned, there's often no symptoms. If the child does have symptoms, the symptoms I've talked about tend to be the more common ones, sometimes even headache, sensitivity to light. And if untreated, this actually could lead to blindness. So it's really important that any child who has GIA is seen by an ophthalmologist. And the frequency and the urgency for that really depends on the risk factors. And there's a whole algorithm as to who needs to be seen with what frequency. And we collaborate with our ophthalmology colleagues to monitor these patients for uveitis. In terms of treatment for GIA, we use what's called a step-up approach, starting with the more benign medications to medications that are more intense on the immune system. And I'll talk about that in a future slide. And physical and occupational therapy are also key in treating GIA, just like in those overuse syndromes. School accommodations are also key with GIA. So things like a 504 plan for children, allowing them to either have an extra set of books so they don't have to carry it home, a locker that's maybe on a lower level or doesn't necessarily use like a dial for the lock if their fingers are affected. They may have a scribe who may take notes for them if they have finger arthritis, things like more time between classes. If they're having trouble walking, an elevator pass, and these are all things we work with the family and the school to make sure they're set in place for the child. So in terms of medication management, I mentioned the step-up approach. And essentially what that leads to, the last step, is a biologic medication. And so what is a biologic medication? So it's essentially, it's a synthesized molecule that's made from biologic structure. So you may see on TV things, medications such as Humira, Enbrel, those are biologic medications. And with the advent of biologic medications and introduction in GIA patients in around the early to mid 90s has really drastically changed the quality of life in GIA patients. So this photo here, this is a kind of a classic photo that's used when discussing GIA of the past. This is a child with untreated GIA, pre-biologics, and you can see she is in a neck collar. She has she can't stand up straight. She is using crutches. You would never see this now because of the advent of biologics. So this is the approach we usually use. So usually when the child first is diagnosed with GIA, we'll start them on an NSAID, so a non-steroidal anti-inflammatory, Motrin, Aleve, Advil, naproxen, which is essentially Aleve. There's a whole variety of them, diclofenac. There's even a topical form now that's over the counter. In mild cases of GIA, this may work, but in the large majority of cases, this will not work. So we will move on to the next step, which is an intra-articular steroid injection. And what this is just an injection of a steroid into the joint. It's a very minor procedure that's done usually in the office. And this usually provides some symptomatic treatment for a few months. And every kid is different. Some children might improve and their arthritis might resolve with this, and some might just come back right away and it might go to the next step, which is a medication called methotrexate, which is a medication that is used in the oncology world, but we use it at much, much lower doses than they do in the oncology world. We use it at what we call anti-inflammatory doses. It's considered a non-biologic DMARD, which is a disease-modifying anti-rheumatic drug. And methotrexate is usually given once a week for our patients, and they can either take it by mouth or they could do a subcutaneous injection. And the last step that we go to, which I would say a fair amount of our patients will need, are the biologic medications. There's a lot of them. They're all listed there. They all affect different parts of our immune system, different cytokines, the most common being TNF inhibitors, so Humira, Enbrel, Remicade. Those are usually the first line, but depending on the child, the type of arthritis they have really will dictate which of these treatments we'll need for the child. And they often will have to go from medication to medication until they find the right one that will work for them. So in terms of long-term outlooks, a remission is definitely possible. Some children may have resolution of their GIA prior to the onset of adulthood. Some may go on to develop arthritis as adults. Every child is very different. Relapses are common, and they're often triggered by viral infections. This tends to be quite common. So these are the other conditions that I see patients for that may cause arthritis. So systemic lupus or lupus can cause arthritis as one of its manifestations. Children with all of these conditions, and I'll go through each of them briefly, have other signs and symptoms other than just arthritis. So things like fever, rash, weight loss, which you will not see in children who have these other types of GIA. So time to see, we're running a little bit short on time here, so I want to fly through these. So lupus, this is the typical rash that we see in lupus, this butterfly rash on the face. Something called juvenile dermatomyositis, which is an inflammation of the muscles and joints. That is a condition in children. They have these specific types of rashes on the knuckles that you see here in this photo. They may have arthritis as part of their condition. Vasculitis, which is an inflammation of the blood vessels. There's a wide variety of these. Kawasaki disease is a vasculitis. HSP is a vasculitis. ANCA-associated vasculitis, such as GPA or MPA, PAN, more of the rare conditions can cause arthritis. Sarcoidosis, again, rare in the pediatric world. Things like rash, arthritis, eye inflammation can be seen in sarcoidosis. And then the periodic fever syndromes, which are essentially fevers that occur with a certain frequency that are not due to an underlying infection. They're often related to a genetic abnormality that causes these frequent fevers. And with the fevers, sometimes these are accompanied by joint pain or joint swelling. So these are all things that I assess for when I'm seeing a patient with arthritis. And just real quickly, other autoimmune or inflammatory conditions that I don't particularly see patients for, but they also cause arthritis or arthralgias. So things like celiac disease, hypothyroidism, inflammatory bowel disease like Crohn's disease or ulcerative colitis may cause arthritis as part of their disease, unfortunately. So I will often work with either the endocrinologist or the gastroenterologist to help manage the arthritis in these conditions. Now with that, I have some educational resources here for you, and this should be recorded, so if you need to go back and look at them, they will be there. And that is all.